Уважаемые студенты, здравствуйте. Сегодня, как и обещал, вы посмотрите фильм «Протезирование зубных рядов с помощью виниров». Фильм на английском языке, но все тут, что показано, все доступно и довольно понятно. Если какие-то вопросы у вас будут непонятны, мы их разберем на практических занятиях. Внимательно смотрите, наблюдайте за ходом фильма. Показаниями для протезирования виниров существуют различные деформации зубных рядов, диастемы, травмы, скученность. Ну и, конечно, изменения цвета, эмали зуба, твердых тканей, различные меловые пятна, пигментации и так далее. Все это вы как раз сейчас посмотрите, как это делается. Непонятные моменты мы с вами обсудим.
Let's go ahead and take a closer look at a couple of no prep cases. One thing I'd like you to keep in mind is that with no prep cases, the patient at the trying appointment, which is where we are on this video right now, can always
Виниры подбираются по форме, размеру и цвету зубов. Вот перед вами диастема между центральными зубами. Вы посмотрите, как она выбирается.
As we look at this no prep case, Eric is really a good no prep case because it's what I would consider an additive case in the sense that it's got multiple diastema between his teeth, especially between the central incisors. And he's got a couple of teeth that are deficient facially as well. There's some alignment issues, and we're really going to take advantage of that because this can be a dramatic before and after that can be achieved quickly through no prep veneers. So we're using the appeal cement from Ivoclar Vivadent here. This is the
Подбираются виниры, которые позволяют расширить сам зуб и убрать эту диастему.
And then through the translucent cement to the tooth and light up the whole tooth and the root and the gingiva and all that good stuff. So we want a translucent cement. So we tried it with the appeal medium value cement, and Eric was very happy with how it looked. So we're preparing him now for the cementation. This is the pumice from Whip Mix called Preppies. It's pre-packaged sterile pumice, and we're using that to clean the teeth, getting out the salivary pellicle, all the trying cement, anything else that might be on those teeth. And we've cleaned and dried them to this place. And you can look at it now and notice that we've got all enamel. So this is one big difference between the prep and the no prep veneers. At this point, we're not worried about any kind of dent and bonding. So by the same token, we don't have to worry about post-operative sensitivity or anything like that. And it's one of the nice things when it comes to a no prep veneer is not having to worry about bond strengths of dentin, which are notoriously fickle. We don't have to worry about all the extra steps and moist bonding and all that stuff that typically we would have to really be paying attention to. Placement of a rubber dam, for example, to keep, all...
Обратите внимание на нижней челюсти в области премоляров и моляров имеются литые вкладки.
And I'm taking it in between the teeth just to clean any little pumice that might be left there as we get ready to cement these. And then we're going to go ahead and etch these teeth. This is regular 37% phosphoric acid. This is Ultra Etch from Ultradent. Usually on these cases, the patient has
Вначале на поверхность зуба наносится протравка, как обычно делается перед пломбированием.
Touches the gingiva, it will not cause any bleeding as long as that marginal gingiva is healthy. And we're going to etch just in this case tooth number 8 and 9, and rinse all the etch off, and then you can dry it and see that frosty look that if you've been doing prep veneers for a long time you haven't seen, because we've been leaving dentin moist. Again, this is all enamel, which certainly simplifies this technique. We don't need a dentin bonding agent without any dentin present, so this is just adhesive. If you think back to a multi-step system, this happens to be
Затем
the
покрывается бондингом.
plus from 3MSB, so we're just using the dark green bottle, the adhesive here, because there is no dentin. So we paint that onto the enamel and then we air thin it. And then on the inside of the veneer, which has already been etched with hydrofluoric acid by the lab, we're going to place silane from 3MSB inside there.
И устанавливаются виниры на клеевую основу, на бондинг.
From Ivoclar Vivadet into the veneer, and then put the two veneers into place on the teeth. And then using these orangewood sticks, I use them with mild to moderate pressure here. Again, this is a high strength ceramic. We're talking 155 megapascals of flexural strength, but we still, until they're bonded in place, really don't want to lean on them with all of our strength. So we're using these orangewood sticks, and I direct one up the long axis of the tooth from the incisal to make sure it's seated all the way there, and then typically push from the facial as well. And a lot of times, if I'm concerned at all, I'll have a stick on the facial pushing the veneer back onto the tooth, and have one at the incisal as well, making sure it doesn't slide down and make the tooth too long. Then we commence with our tack and wave technique, where we take our curing light and we hold it about 2 to 3 inches above the teeth and turn it on for 15 to 20 seconds. And really what we're trying to accomplish here is just get the appeal, the resin cement.
Идет световое отвердение бондинга. Излишки его убираются из пришеечной области.
Along the margin, we'll pull some of the cement out from underneath the margin, and that's no good. Once we get to its gel state, when we have a nice closed margin on a restoration, it cleaves off the cement right at the margin, so that we're able to clean it up like this in one piece. And really is simplistic. This is the part of adhesive dentistry, at least with veneers, that the dentists I talk to hate. Most dentists say, boy, I'd love to prep veneers and impress them, and I don't even mind temporizing them anymore. But this is the one step they don't like, is putting these on, veneers, putting on 4, 8, or 10 veneers. It can be very difficult and take a good number of hours. And with the no prep technique, this goes a lot faster, so we're not as worried about dentin bonding. So we don't have to have the strict degree of isolation. And with the tack and wave, it allows us to clean up a little easier. Once we clean up the excess cement from the gingival margin,
Еще раз засвечивается лампой для окончательной полимеризации бондинга. Обязательно проходят межзубные промежутки сепарационной нитью.
Kind of stretching. We haven't cleaned the lingual yet. In fact, we will tack and wave on the lingual before we clean that excess cement.
Чтобы избежать развития гингивита. И с проксимальной поверхности еще раз производится полимеризация светом.
Scalpel, we can clean that up with a brownie wheel. You'll see a couple different ways we can clean that up. Once we've removed the resin cement from in between the teeth and from the distal aspects of both of these teeth, now we're going to go in and do our final curing. So unlike the tack and wave, where we're 2 to 3 inches away from the teeth, with the final cure, we're basically sending curing light right under the teeth and curing it to make sure that it is in fact completely cured. So as we go into the floss, oftentimes we'll go into the contact and then take the loose end of the floss that we're holding onto towards the lingual and pull everything through towards the lingual so we don't pop the veneers off. Once we've got the two centrals in place and have them completely cleaned up, we move on to the next two teeth, in this case the lateral incisor or the cuspid. It's certainly acceptable to throw the first bicuspid in or the second bicuspid as well if you want to deal with four of those teeth. But
Чтобы центральные зубы не бросали все в глаза, дополнительно с той и с другой стороны обрабатывают боковые резцы и клыки.
we've etched the lateral and the cuspid at this point. We have rinsed off all the acid etch after leaving it on for 15 seconds on the enamel. And then we place the dark green adhesive from the Scotch bond system on it, air thin it, and then the inside veneer we treat the same way with the silane and the bonding agent. We air thin it. Again, because these veneers are so thin, these 0.3 millimeter veneers, we really don't need to pre-cure any of this stuff. We kind of make a sandwich out of it and cure it once it's on the tooth. So when the veneer's in place and we're curing it, we're curing through the veneer and we're curing the bonding agent on the inside of the veneer, we're curing the resin cement, and we're curing the bonding agent that's on the tooth all at the same time. And again, we're doing tack and wave with the curing light a couple of inches away, and you can see that we're able to remove the excess material very easily. Again, notice the floss technique. We go through the contact and then pull both ends towards the lingual. Both ends towards the lingual. If we pulled both ends out to the facial, that would act to pop the veneer off towards the facial, and we don't want to do that. If we took the floss and went down into the contact and pulled it straight out, that might do the same thing. Now, once the veneers are clearly bonded in place, it doesn't matter what you do, but just by force of habit, I pull both ends out towards the lingual when I know that the veneers are not completely cured into place, just so we don't bother anything or disturb the placement of the veneer. Here's a safe-sided strip from Brassler. You'll notice it has no abrasive on either side of it.
Если нитью не удается пройти межзубной промежуток, берется сепарационная полоска и с помощью сепарационной пластинки вы проходите межзубной промежуток.
The serrated edge will take out any resin cement that's stuck either in the contact or in the gingival embrasure, and at the same time it doesn't create an open contact because it doesn't cut on either side. This is the Brownie wheel that you see being used. This is from the old cat's gold technique, and what we're using it for here is to remove resin cement from the facial surface.
Затем идет полировка мягкими щетками. С нижней стороны головкой алмазной убираются излишки и создается форма. Вот перед вами уже зубной ряд, покрытый винирами. Для сравнения, что было и что стало.
Our next patient, Jerica, really lends herself to a no-prep approach as well. She has mentioned she doesn't want to be drilled on, doesn't want
Вот
local
перед вами
anesthesia. So, again, she's a good no-prep candidate right from the
следующий
get-go.
фильм.
Look at her, she's an additive case. She's got multiple
Здесь
diamonds
идет
on
исправление
it, some
конфигурации
some chips that are out of there. So, again, a good
центральных зубов, боковых резцов,
we've gone ahead and taken our polyvinyl
и также
depression, sent it off to
убирается диастема.
veneers back, and we're trying them in right now with the clear cement. And once we try them in, you can see right there saying, "Oh my gosh!" As she looks at it for the first time in the mirror, and that's kind of neat that she would have that. Remember, again, that patients have different standards than we do as dentists. She's amazed that we could put those in and change her appearance so quickly. Now we know we could have done even more with prep veneers, but no prep veneers. Sometimes you got to look at it from the patient's point of view and the simplicity of what we're able to do. We do explain to them, the pros and cons of doing it this way and the other way, so they fully know what they're signing up for when we do these no prep veneers, and they know they're going to have to keep them cleaner than regular prep veneers because of the gingival margin. So she looks at them and she loves how they look, so we're going to go through the same steps as on the last case. We're going to go ahead and etch the teeth with the 37% phosphoric acid, rinse those off, place the adhesive, the dark green adhesive from the Scotch bond system, and then treat the inside of the veneers the same way. We're going to place the silane, evaporate it, and then put the adhesive on the inside of the veneer, and then squirt the clear appeal cement into that. Again, it's the medium value and the 0 shade. And using the orange wood sticks to hold the two central incisors in place as we're doing here, we're going to tack and wave, and I'll check it with the Explorer. If it needs a little more time, we'll do a little more tack and wave. This looks like it's set up pretty good here. Sometimes just one of the teeth needs just a little more, a few more seconds of tack and wave here. You really don't want to overcook it at this point and over-cure it. So we do it on the conservative side. We may have to go in a second time and cure for 5 more seconds to get it to the gel state. Once we've gone ahead and cleaned up tooth 8 and 9, in this case we're putting on teeth number 10 and 11 here. Again, I prefer to do them 2 at a time, just so I don't have 4 teeth I'm looking at. I just have 2 teeth that I'm looking at, even though it probably costs me a few minutes in terms of time. We're making occlusal adjustments here, and again using the brownie cups that I use so many of every time I do these veneers, because it really allows me to clean cured clear veneer cement off the front of the veneers without doing anything to hurt the glaze or the finish of the porcelain veneer itself. Go through and double check all our contacts with the dental floss. If there are anywhere we can't get through, we'll go in with a metal strip, the serrated safe-sided strip from Brasseler. If there's any areas as we look around where it's left a little bit bulky, or we have an area that seems excessively bulky, from the laboratory for strength perhaps. Now that it's bonded into place, we can take a handpiece and go in and recontour any of these areas. And again, you can see this is day of delivery, and we irritated the gingiva a little bit on that one tooth over on her right hand side as we did it. But when you look at the before and after again on her, she was thrilled. Is it a perfect case? Well, it's not perfect from the standpoint of, had we prepped it, we would really have total control over the dimensions of the veneers. We could have done some gingival recontouring.
Некрасивая форма зубов исправлена. Образуется ровный зубной ряд.
I've had the laboratory fabricate some no-prep veneers here, and I've gone ahead and quickly glued them to some Typodont teeth.
Еще раз хочу обратить ваше внимание, что виниры, вкладки делайте обязательно на живых зубах. Если зуб депульпирован, лучше сразу сделать коронки. Здесь доктор показывает, что винир, он ложится в пришеечной области, имеет уступ. By some clinicians that to counteract this, that once the veneers are put into place, you would take a burr and go in and recontour the porcelain here. И здесь может собираться пищевые остатки, микрофлора полости рта. И карбидной головочкой все эти места должны быть сошлифованы.
Not only that, but if there was gingiva present here, obviously I would run the risk of lacerating the gingiva as well. So I don't feel totally comfortable doing this out of the mouth, let alone if this was still intraoral and I was trying to deal with biologic tissues around here. So I'm going to spend just a couple seconds doing this, and let's see what I'm able to do. Okay. So I was really able to cheat here. I mean, I'm able to take the tooth and turn it in all kinds of directions that I'd never be able to do intraorally. And the same thing with the handpiece, being able to go into angles that would clearly violate the gingiva.
Объясняет, что эти уступы уже убраны, и пища здесь уже практически застревать не будет. Discuss the matter of what I did to the porcelain. A lot of porcelain manufacturers will tell you they prefer you not to
touch a carbide or a diamond to porcelain once it's glazed, especially in a thin area like the margin, because of the microfractures that can be set up in the porcelain. So that's another negative of doing this once they're bonded into place. So I just want you to be aware of this potential pitfall with the no prep veneer technique. Now, one of the ways to kind of minimize this risk is to place this margin slightly supragingival, which is what I do in all my no prep cases. And by placing it slightly supragingival, we hopefully assure ourselves of the patient cleansing it 2 or 3 times a day with their toothbrush. If you place a margin like this subgingival, we're going to cause gingivitis. It won't be very pretty when the patient smiles aesthetically, and we will probably cause some gingival recession on our own that will end up making this a supragingival margin down the road. So we know going into this we're going to have an issue here. In my mind, as long as we keep this slightly supragingival, we're going to minimize any risk that this may cause to the patient and the health of their periodontium. If you do want to go in and refine the gingival margin, make sure that you protect the tissue either with a Zykyber retractor or a cord pack or something to move the tissue back while you go in and refine that gingival margin. Let's go ahead and take a look at a couple of cases that utilize conventional preparation. I want to give you 2 great little tips regarding anesthesia. The first one is the topical anesthesia that we use. It's called Profound, and it's available from a pharmacy called Stevens Pharmacy. And the great thing about Profound, it's the strongest topical anesthetic I've ever used. It's a combination of prilocaine, tetracaine, and lidocaine. And it does a fantastic job.
Сейчас вы увидите следующую методику, которая здесь будет связана уже с непосредственно с препарированием. Чтобы начать препарирование, необходимо сделать анестезию. Здесь показана анестезия делать септонестом. Переходную складку в области препарируемых зубов.
If you're going to be doing a full arch, it's going to be taking the better part of 4 hours. You probably want to use something like Marcaine, but for standard cases, I love Septicaine because of how well it's absorbed. But there is some stuff in the literature about using a 4% anesthetic like Septicaine for blocks. So I still use 2% lidocaine for blocks and use Septicaine for all infiltrations. This is a female patient, 34 years old, who has multiple diastema and always felt that her teeth were short and didn't like the appearance. So when we talked to her about lengthening, I had a Biotemp stent made that could be placed on the virgin teeth, and that is in place right now. Or party teeth, as we like to call them. She could put these in, and she kept saying, "I'm done, just let me take this home." And of course, it wasn't permanent. So we placed this stent in place and let her take a look at it and make sure she's happy with the length. Once we determine she's happy with the length, we're going to accomplish that length by lengthening the incisal edge just slightly. Most of our length is going to come from gingival reduction. So we place the
Здесь частично идет иссечение сначала десневого края с помощью лазера.
Because of how much gingiva we're removing and because of her complaint that she didn't like her gummy smile, we're going to have to remove enough tissue and it's going to impinge on the bone. It's going to violate the biological width. So we know that on this case we are in fact going to have to lay a flap here in the anterior and recontour the bone and bring the bone back down so it's 3 millimeters away from the edge of our restorative margin, in this case the veneer. So as we remove the tissue, we try the stent back into place, and this is just a way for us to double check and make sure we have removed enough tissue. So this can be placed throughout the procedure back into place. We'll do it when we're working on the osseous tissue as well, and here we're using the diode laser to remove just a little more tissue where we hadn't taken off quite enough. So it's really nice having that stent. Not only do we not have to freehand what we're doing with the gingival tissues, but we can replace it multiple times to see how quickly we're making progress here. Using a little hydrogen peroxide here, just it helps clean up some of the tissue tags when you use it, the Dento infusion tip from Ultradent, and here we're just using a hand instrument to remove some tissue tags. And once we see that we've removed enough tissue, we're going to put a couple vertical releasing flaps here. And again, we're using the tip of the scalpel and just running it through the sulcus along to the bone right here. And what we're going to do is release the facial flap of tissue so we can actually see where the bone is. Some dentists try to do this closed. I find it almost impossible to do it closed and be able to see where we are. So we have reflected a flap, as you see here, and we're just cleaning up the bone a little bit with a Rhodes back action chisel. And what we're going to do as we reflect the rest of this flap is put the stent back in and measure from the edge of where the proposed veneer margin is going to be to the bone. And we need to have 3 millimeters of space in between those. Not 2.8, 2.7, 2.9. It needs to be 3. So this is the water laser, YSGG laser from BioLaser. It's a hard soft tissue laser, and here it's being used to remove bony tissue. So with the stent in place, we can see where we need to
Вы вот
remove
внизу
tissue from.
видите
So we go around
рекламу
the teeth and following the
аппаратуры,
cotton
которая
remove
применяется
enough tissue
при
so
данной
the bone
методике.
is 3 millimeters away, no less, from the edge of our proposed restorative margin. Now we're using some 5/0 silk suture to close this flap. We do this by starting the knot on the lingual. We start the suture, I should say, on the lingual, and we go under the interproximal contacts if they're present, through the flap on the facial, back under the contact, and tie the knot on the lingual so it's not apparent. You can see the sutures here are really not an aesthetic problem, and that's nice. That's how people like it to look. And patient came back for post-op check 5 days later. Sutures were removed, and healing was progressing fine. So she came back later, about 8 weeks later. We took a shade reading with the Vita Easy shade to get an idea of where we were starting. And she definitely wants to go lighter. One of the things she had in mind was white teeth. You can see as we place our depth cuts for the veneers, we're using
И
our
вот
3
начинается препарирование
handpiece so that the uppermost barrel and the one all the way down by the gingival margin,
специальными борами. Делаются насечки на глубину 5 миллиметров.
Right now we're blending the depth cuts on the facial surfaces. Doing this with a rather large diamond burr. The bigger the burr, the faster the cuts go. And obviously it cuts a lot smoother than a thin burr, so I like to use a large burr as we're reducing this. We're going to shoe the buccal cusps on the bicuspids as well, the first and second bi. So we're reducing the buccal cusp of each of those 1.5 millimeters as well, and that will blend with our occlusal depth cut that's going to go all the way to the central groove. As we continue to prepare the teeth, we now blend together our incisal edge reductions. And you can see right now the burr is perpendicular to the long axis of the tooth. We're going to tilt that at a 30-degree angle back towards the lingual to give us our lingual margin. And I'll do that on a model elsewhere in this DVD so you can see exactly what I'm talking about. Now we're packing our cord now that the gross preparation has been done. This is a 00 cord from Ultradent that's being packed around the teeth.
Это укладывается ретракционная нить для того, чтобы как следует проснять пришеечную область.
Then I grab the loose ends on the lingual and pull it almost tight, and then just use the cord packer to pack the rest of it in. I do not need to pack on the lingual because these are veneers and the margin is going to stop well above the tissue. So
Нить также служит для гемостаза.
Papilla around the facial to the opposite papilla. It does not go on the lingual. We can do any touch-up preps we want here. Drop the margins a little farther down, a little closer to the gingival. We're using a 3M SB Softlex disc here to round off any sharp incisal edge corners. That's critical because when the impression is taken and it's sent to the laboratory, any of those sharp little angles will break off in the impression after the lab pours the master model, which will lead to ill-fitting restorations. We are now packing the top cord. This is a size 2 cord from Ultradent. That's going to sit in place for 8 to 10 minutes. After 8 to 10 minutes, we will remove the top cord, leaving the bottom cord, the 00 cord, in place. We're syringing around the teeth. This is capture impression material from Glidewell Direct.
Силиконовая масса снимается в оттиск.
And syringe around the preps. And this is a tube viscosity impression material. So as I'm finishing expressing the material onto the prep, she has used an impression tray, a metal one, a perforated one, my favorite kind of tray, and filled it with tray material. Of course, the custom tray would have worked a little better and actually saved some impression material as well, but we had not had one made. Once the impressions made
Двухслойный
up, verified for
слепок
accuracy, we have the patient bite down
снимается.
to our bite registration material. This is capture hard bite, again from Glidewell Direct. This takes 90 seconds to get to its final set, and we
Затем
have the incisal edges
регистратором
and the
определяют
opposing teeth in this bite registration.
центральное соотношение
We
челюстей.
have used the putty wash technique on the patient's diagnostic wax-up. And this is our putty wash hockey puck or stent if you want, and it's been filled with the bleach shade Visichrome material and put into place in the patient's mouth and allowed to seat completely for 4 to 5 minutes. You can see a little piece of flash here, and I will take that off. And again, when you look at these temporaries right off the bat, there's just not a lot of work that needs to be done. And this really is not only the best looking, but the easiest way to make temps like this, just by locking them into place. And here we're on the lingual surface, just removing any excess we might have. Again, there won't be too much excess on the facial if we use that technique where we clean out the sulcus and reduce the gingival third with like a
Ну
half
вот показывают штангенциркулем,
just to make sure that the length that we have is the
насколько
length
произошло
that
увеличение коронок.
if it's not, we can use sandpaper discs. You know, if we wanted to get 10.5 millimeters in length, and by the time we transfer it to the patient's mouth, we have 11. We can always make it shorter on the temporary, so that's not a big problem. Sometimes the patient will go home and wear the temporaries for a week and call back and say, you know what, I'm having problems with, you know, F's and V's and things like that. And that's a sign that, you know, we've lengthened the incisal edge a little too much, and phonetically their lower lip will not clear the upper incisal edges on those sounds, so we need to be careful with that too. We had a good feeling it wasn't going to happen on this patient because of the fact that we did most of our lengthening at the gingival, not the incisal edge. Here she is 2 weeks later for her veneer seats. You can see the temps look very natural, and you know, as she smiles, we don't see a lot of tissue, which is what she wanted. You know, she had complained about her gummy smile and
Вот
wanted that
как
corrected.
исправляется форма, цвет, размер.
We're going to try in the veneers one by one to check for fit and check for contacts. And once we have verified the fit, we'll try them in together with a translucent try and paste. Again, this is Nexus Clear from Kerr. And the try and paste gives us an idea of what effect it's going to have on the shade. Since we're using a clear shade, there shouldn't be any effect. At the same time, it also helps hold the veneer into place so the patient can take a mirror and look at it without them all falling out. Once the patient has looked at the veneers in the mirror and approves of them, or wants changes made, you know, thinks the cuspids are too pointy or something like that, once she likes them, we will remove those and rinse out the water-soluble try and paste and get ready for our final cementation. So once the patient has approved of the veneers, we go ahead and try them in. We're going to start by placing 8 and 9, as we always do alone, again using the self-etching bonding agent. And placing 8 and 9, again, your goal is to cure it just enough so that you can clean these up just like they were standard crown and bridge restorations. So we're going to cure them by tacking and waving and then clearing off everything in the gel state. And while it's still soft at that point, we'll take the light half on the gingiva and half on the tooth and finish the cure at the gingival margin. And then take our dental floss and run it interproximally and clean up the rest of the tooth before curing it completely. We do 8 and 9 first because, let's face it, if the smile is off there, the entire case is blown. So we really need to make sure that 8 and 9 are right. You know, standing alone and together in combination. If those two teeth are wrong, it really is difficult to have a case turn out.
Значит, вы предыдущие кадры видели, были сделаны виниры временные, провизорные, пока готовились виниры из фарфора. И сейчас идет припасовка и фиксация.
We're going in and checking the bite. Again, a disposable scalpel can be used to remove any excess resin cement that may be on the facial surface of the veneers. And I also like the brownie wheel from the Caswell Brownie Greenie set. Works very well for removing the cement. You can see we have a shade difference between the uppers and the lowers, and I talk to patients and let them know it's not a big deal. I would say most of our patients, if not all of them, who get maxillary veneers do end up bleaching their lower teeth, but again, we point out to them that when people smile, you see
С оральной вестибулярной стороны идет окончательная полировка.
rarely do you see both at the same time, unless you've got a huge smile and you're a model and you would see it photographed. So this patient's the same way. She's going to go ahead and bleach her lower teeth now that we're done with the upper ones. And we were able to achieve her goals. We got rid of her gummy smile. We closed the spaces, and we had a significant color change, and they got a lot whiter than they were before. So again, with the use of a biotemp stent on the virgin teeth, we were able to determine our final tooth size and get it approved by the patient before we began the gingival surgery. And after that was all done, the veneers were rather straightforward. We finished this case, and the patient was extremely happy with how it turned out, and was very grateful and very happy, as were we.
Вот. Исправили практически полностью зубной ряд.
On this case, we'll be doing a combination of porcelain veneers and some gingival recontouring. As you can see,
Еще одна методика демонстрируется вам.
10.5 millimeters long, and these teeth are about 9 millimeters long. So we're going to add a little length at the gingival and just a little at the incisal edge as well to get a little closer to that number. I've had a biotemp stent.
Исправление формы и размера зубов.
Now this is at 10.5 millimeters for the central incisor length, and the other teeth are sized according to golden proportion. So we're able to try in this stent over the virgin teeth and then hand a mirror to the patient and let them take a look at it and see what they think about our proposed increase in length, both at the gingival level and the incisal edge. So the patient has a chance to look at it and say, well, I think, that looks too long, or that looks great. We're going to do a little probing here. The patient's already been anesthetized. So in addition to probing, you'll notice we go right
К сожалению, здесь не показывают лабораторные этапы изготовления виниров, а идет только клиника практически.
To the crest of the bone, and we have plenty here, over 4.5. So we're going to be able to just recontour the tissue a little bit and not have to worry about the bone level. We're far enough away. With the stent in place, we're now taking a micro-tip surgical marker and just marking the outline around the stent where the ideal gingival contours would be for this case. And now we're using our diode laser, which is a laser smile from BioLaser.
То же самое лазером иссякаются места, где была отметка маркером. Идет удлинение коронки. Снимается частично слизистая в области пришечной области и зубочисневые сосочки.
And you can see how easily the tissue kind of peels off. Of course, one of the big advantages of doing it this way is that there's no bleeding at all in this technique, unless you have an area where the gingiva was already irritated or inflamed for some reason. The laser can cause just a little bit of bleeding in an area like that. You'll notice we place the stent back on again to measure how much progress we've made. If you think about it, with the stent in place, when you make the dots around the stent, the dots are really above the stent and a little farther or a little higher than you need them to be. So we cut almost all the way to the dots and not all the way to the dots. So in other words, because of the position of the dots above where the stent is, if you cut with the laser T, you can no longer see the dots. You would in fact have cut maybe 1/4 millimeter too much off. We began our veneer preparation with a depth cut. This is a 3-barrel diamond, you'll notice, and we're going to use this. We place it into the tooth. This is a 0.5 millimeter reduction that we're going to accomplish here. And you can see how the band that's not cutting, you can see the mark of the metal on the tooth. And that's crucial to make sure that you have in fact sunk that depth cutter all the way down to its depth in the tooth. You need to see those metal lines. You need to see the smooth section of the shank against the tooth to know that you've done it far enough. And you need to rotate that so all three of those barrels go to their full depth. They won't all do it at the same time either, which is why you need to rotate the head of the handpiece. Once the facial depth cuts are done, we're using a diamond, really any diamond you want here. The bigger the diamond, the faster this will go, so I would encourage you to use a large diamond. And we're basically going in and connecting the three depth cuts that we've placed, keeping in mind that there are in fact three planes on the facial surface of this tooth.
Зуб препарируется и с оральной, и фациальной стороны, то есть vestibularная и небная сторона зубов.
If it was a PFM, that would be a spot that would have a tendency to be very opaque. In an all ceramic crown, we're just going to have teeth that stick out too far to the facial and have kind of that buck look. So we want to make sure that when we're done reducing the facial aspect of this tooth, that we maintain the same three planes that are there on the virgin tooth. Just a tiny bit of bleeding there between two of the teeth from the handpiece, not the laser. And we placed a little X-Bacil there from Kerr Corporation that will sit on that tissue and stop any bleeding to allow us to work in that area a little bit easier. This is a red grit 30 micron diamond that we're using to smooth off and get a nice finish. And now we're going in and squirting our impression material. This, of course, is a syringe material. And we're going to use this around the preps themselves while my assistant loads the tray for us with the tray material. I like two viscosities because this is a little runnier and it's a little easier to push the material subgingival with the thicker, more viscous tray material that my assistant's currently loading. Because the margins of these restorations were supergingival, we were able to do this without having to pack any
То же самое снимается двуслойный оттиск силиконовой массы.
After 3 minutes and take a closer look at it. We're going to go ahead and take a bite registration for the laboratory now. You can see we're pretty generous in the way we squirt this onto the teeth, but remember, all we're looking for on a bite registration is we want to register the incisal edges of the
Регистратом определяется окклюзия.
All the other material is going to be cut off. We don't want to have any soft tissue detail, and it does not even need to cover the entire prep down to the gingival. We simply want to be able to have enough material to record the incisal edges of both teeth. Anything else will be an interference and needs to be cut back with a Bart Parker. Here's our diagnostic wax-up for the case. Some important points that I'd like to show here. This is going to determine the shape and size of our temporaries, and I'm taking a sharp instrument. This is an Explorer, of course, and just going right along the gingival sulcus. You can see where I'm carving out just any excess.
Моделируется на моделях
I really want to define the gingival
сами
margin.
виниры.
You can do this with the tip of a half Hollenbeck instrument, or it can be done with an Explorer as well. But really, in the area of this model where things are just a little sloppy, I just want to be able to take a sharp pointed instrument and define the gingival margin here. And you'll see why in a minute. It's because when we take a putty wash impression of this diagnostic wax up for our temporaries, I really want to make sure that we have a nice stop here. So in other words, as I use the Explorer to define this gingival margin, when we take our putty wash impression, it's going to stop the temporary material from going beyond here. And this is going to lead to a set of lock-on temporary veneers that needs almost no finishing. And so spending this small amount of time right now is going to pay large dividends when it comes to finishing the veneers. I've mixed up a putty material, just a standard impression putty material, mix the two components together, and we're putting this over the diagnostic wax up after I've defined the sulcus with the Explorer and after I've used my carving instrument to flatten the cervical third so that it's not bulbous. We're going to wait 4 minutes for this to set. It takes a couple extra minutes out of the mouth, actually. Then we'll go ahead and remove that from the model. And now we're going to go ahead and take some syringe material, again, some light body syringe material, squirt it into the putty, and put it down on the model. This is really going to grab some good detail for us. So this is an important step. This is Lux Attempt that we're using. We're squirting this into our putty wash combo. This has a shade of an A1, and we're now squirting it in here. A lot of times I'll use a bleaching shade in cases like this to show patients what really white teeth look like if they insist on having white teeth. This patient, a male, age 40, did not insist on having white teeth, so I was able to tell him we use an A1. We just seat it into place completely. Again, this is the impression from the diagnostic wax up. We're going to wait 3 or 4 minutes and let that material set completely. We're locking this onto the teeth. Once it sets completely, we take our putty wash off and let our patient take his first look at it, and it looks fabulous. It looks fabulous every time. And the reason why is the putty wash is very, very accurate. Bisacryl is a very pretty material, and our impression is coming from a diagnostic wax up. So in the case of this patient, we've reshaped some of the teeth. We've gotten rid of the rotations. And as a result, his teeth are in a much better alignment, and the color is much better than when he walked in the door. So we have a very easy way to be able to do temporaries here. Just a little finishing is
То же
necessary around
самое.
the margins here. I'm
Это
spending maybe
делается,
5 to
пока
10 seconds on each tooth with this
временные
very
виниры
slow. It's an electric handpiece running very slow. Really, I'm just going around the sulcus, making sure there's no excess material in there. Now I have some material. This is Luxa Glaze. And I'm using a paintbrush to put this onto our temporary veneers. This is
перед вами реклама
glaze ceramic look. As I
люксоглаз.
cross the midline and I'm placing on the other side, my assistant will begin to cure it just 10 seconds on each tooth. This glaze material on the bisacryl will also help to stop any stains the patient might pick up from drinking coffee
Лампа, с помощью
or
которой
eating, colored foods. And literally about 15
работают.
minutes later, this is how the temporaries look. And we are finished. Again, we have locked these into place. These are mechanically held into place. We do not try to wiggle them off and then re-cement them. For the most part, the material is so thin that if we did try to do that, every time we try to take it off, it would probably break. Patient comes back 2 weeks later. During that 2-week interval, we have them use anything they can. A rubber tip stimulator around the gum tissue. We have them rinse with tooth gum and tonic from Dental Herb Company. We want to keep the gingiva nice and healthy. And I'm using a 57 burr just to make some slots in the front of these veneers. And what we're going to do is pop these off in pieces. We know we're going to destroy these temporaries, and that's okay, because we saved our putty wash matrix from last time. And so if we do need to make new temporaries today, if the patient doesn't really like the veneers, again, in 15 minutes we can make a new set of temps. So we just destroy these.
Временные коронки снимаются, когда уже работа готова. И на их место припасовываются, а потом фиксируются. Дополнительно идет протравка.
The papilla, or it pushed a sharp piece of bisacryl down into it as well. I wear loops, for this entire procedure, but that's certainly one of the parts where loops are very helpful. It's very easy to leave a little piece of temporary material between a couple of teeth and not notice it, as you're trying to go in there. And if it's still in place when you're doing this part, seating the veneers, it's gonna make the veneer hang up. So you really need to be careful.
Ну, это уже готовые виниры. Припасовываются и фиксируются.
Next step is we try in all the veneers one by one. We don't use any try and paste in the first stage because we want to be able to evaluate the marginal fit. Once we've had a chance to evaluate the fit and the contacts, we now try these veneers in with the try and cement. This happens to be Clear Nexus from Kerr. And I prefer the clear or transparent shades because I want the light to go through the veneer, through the cement, and then into the tooth and light the whole tooth up like a fiber optic bundle. So hopefully we don't have to try to do too much coloration or opaquing with the cement because it can lead to veneers that don't look as real as ones where translucent veneer cement was used. In this case, we made 2 different sets of veneers for our patient. One of them happened to be a hand-built feldspathic set of veneers, and the other one happened to be a pressed set of veneers. So as we're testing them and we're putting the first one on, it looks a little bit darker than I wanted than an A1, so I'm using the Vita Easy shade to check the restoration in the patient's mouth, and it's telling me, yes, this is a little darker than you were going for. And so we're letting the patient take a look at it now, and the patient plays a big part in deciding which of these 2 restorations we're going to end up cementing in the mouth. So once the patient's had a chance to see these restorations, we take it out. We'll rinse off the water-soluble try and cement from the teeth and the inside of the veneers. And now using the same shade of veneer cement, we are trying in the other set of veneers to see if the patient likes these more. The patient's allowed to see the other set of pressed veneers. This is using a proprietary ceramic called Prismatic from Glidewell Laboratories, and that happened to be the one they liked. So at this point, we're using some pre-packaged pumice. This is Preppies from Whip Mix, and we're using it in a prophy cup to clean off the teeth and remove any debris. Be really careful not to slam the prophy cup into the gingival tissues. At this point, certainly we would like to avoid any and all bleeding if possible so that we don't contaminate any of the veneer cement as we start to put it in place. So just washing, and then we will dry the preparations. We're going to place these on with a self-etching dent and bonding agent. And we're going to use Brush and Bond from Parkel. And we're going to do the two central incisors first. And so on 8 and 9, we've gone ahead and etched those two teeth. Again, not total etch, so you won't see any blue gel here. This is self-etch. And then for about 5 seconds, we're going to evaporate with some oil-free, water-free air. And then go ahead and cure on these two teeth, so we know we've got hybrid layer formation here. And then once we've cured 8 and 9, my assistant will load both the veneers with the Nexus clear cement, and we will put those into place. And then our technique's going to be just a little bit different from how we used to do it. Something called tack and wave, where we're going to hold the curing light up above the veneers, maybe 3 inches, 2 or 3 inches away from the veneers, move it back and forth.
Фиксация идет на бондинговую светополимеризующую систему.
The cement that we have accelerated into its gel state. We want to get it right to the stage where we can sneak an explorer.
Излишки снимаются
Just basically like it was crown and bridge cement. I mean, really the goal of placing
ультразвуковым скальпелем.
the cleanup be as easy as if this were crown and bridge cementation. You can see the explorer going under here, and I'm able to really remove this whole facial bead on tooth number 8 and 9 at the same time, like I was doing routine crown and bridge cementation and not doing some veneers. You can see how clear that cement is as it comes off the teeth, and how nice that's going to be under that veneer for letting the light shine through the porcelain and get to the tooth. You need to be careful here. You're going to have some excess cement that's going to spill over to teeth number 7 and 10. So since you have not etched or bonded those teeth yet, it is pretty easy to clean the cement off those two teeth. Just wait again until it gets to its gel state. If floss won't go down, and it didn't in this case, I'm going to take
Обязательно проходятся межзубные промежутки сепарационной пластинкой.
And you can take that and use that down in between the teeth as well. And both of these do an excellent job of being able to get to cement interproximally that was bonded. Accidentally too, if you need to, you can use a mosquito tip burr, as we're doing here, and a high-speed handpiece to remove a little piece of cement if necessary once it gets rock hard. Now we're going to go ahead and working on the left-hand side, we've got a couple teeth that we're go ahead and placing our self-etching primer on. We've now placed the lateral incisor and the cuspid on this side. Depending on how the case is going, sometimes I will place the lateral, the cuspid, the first and second by all at the same time. It kind of depends, what your gingival condition's like and what your, how busy you're being kept in terms of moisture control. So on those cases where everything's going perfectly, it's certainly acceptable, and I will often place all 4 veneers on that side at the same time. So in this case, I did the lateral and the cuspid on one side, then the bicuspids, and then went to the other side and kind of did them Here we're using some brownie wheels. Love these brownie wheels. It's such a great way to clean up excess cement off the facial surface. This is from our old casserole technique, if you remember brownies and greenies. And the reason the brownies work so well is
Окончательно
they're just soft rubber
виниры
ducks, so they will not do anything
шлифуются и
to the structure
полируются.
or porcelain. All they will do is work on the resin cement itself. So it's a great way to be able to remove cement from porcelain or tooth. This is the Dialite Ultra Polishing Kit from Brassler being used in an electric handpiece, a cable electric handpiece, so that we can go in and put a final polish here with a ton of torque. And torque is the secret to polishing porcelain intraorally. I used to be afraid to touch porcelain for fear that I would never get that same shine back on it that the lab had given it. And it wasn't like the lab was reglazing it. I mistakenly thought the lab would reglaze anything I sent back. But they wouldn't. They were just using a high torque electric handpiece, and that's what I'm able to do with mine now.
Here's a little disposable scalpel being used for the same purpose, being run along the facial surface just to check and see if there's any additional resin cement on the facial surface of the veneers. With the scalpel, you can slide it along and pop off or cleave off any cement that is stuck to the glazed ceramic surface. It's not bonded to the surface, it's just usually stuck in the surface texture, and the scalpel gets it off reasonably well. And at the very end here, we're using an enhanced cup just to polish around the margins and just to pick up any other composite that might be on the facial aspect or interproximally of the veneers. It tends to show up once you've hit it with the enhanced cup. We finished this case and the patient was extremely happy with how it turned out and was very grateful and very happy, as were we. One of the mistakes dentists often make that we notice here in the laboratory is
Вот
to
идет
take a
исправление
case like this where we have some pre-existing
зубного ряда.
problems and to not correctly
Нарушена дуга,
prepare the case. And you can tell when you look at the prepared model because the teeth
диспозиция зубов,
and that's really what I want to show you
боковых
today.
резцов.
I want to get you thinking about correcting
Сейчас
this problem
посмотрите, как
before you
будете
begin to
исправлять
replace teeth for porcelain veneers. And the way I'm going to show you
эту
how to do it today
деформацию.
might be, a little more work than you're willing to do on a day in, day out basis. But at least if you have these concepts in mind when you prepare your veneer cases, you can kind of do some of this work in your head. What I want to do is a combination of adding composite and a combination of enamelplasty to solve our arch form dilemma before we begin to place depth cuts for the veneers themselves. So again, we're going to look at teeth that are placed or positioned too far to the facial, and we're going to perform some enamelplasty here. And on the teeth that are positioned too far to the lingual, or in this case rotated towards the mesial, we're going to add some composite here. You can do this with a diagnostic wax-up as well if you're going to have the lab do it, but oftentimes I'll sit down with a model like this and just do it quickly myself. This doesn't need to look good at all. In fact, it's just going to be kind of sloppy the way we add composite and remove some enamel, if this were in fact enamel, to kind of correct this arch form. And we're going to keep that in mind because that's exactly what we want to do in the mouth prior to preparation. So let's see what that would look like. I'm going to use a little unfilled bonding agent here. This happens to be some of the adhesive from the 3MSB Scotch Bond system. And that's going to facilitate the placement of the composite on the teeth, and we'll just use a little A1.
Это рекламируются материалы, с помощью
So
которых
again, anywhere where we are deficient in tooth structure, where a tooth has been
будут
rotated,
изготавливаться
as a result, we're
виниры.
short on tooth structure, for example, to the facial. We're going to remove some composite and place it on that area on the tooth to give ourselves a better idea of what this arch needs to look like. In the mouth, this would be the step that you could certainly skip if you wanted to make this a little bit faster. You wouldn't have to do this part where you add the composite. You just want to do the enamelplasty step that we'll get to next. But I just want to show you basically and get you thinking about how we want to correct this arch prior to preparation, because that makes all the difference in the world. Patients investing a lot of money for their veneers because they want to end up with a somewhat ideal, if not a perfectly ideal smile, and we owe it to them to do some case planning before we start the preparation to make sure we can achieve that objective. So again, with the tooth that's been rotated towards the mesial, that's deficient on the mesial, we're going to add some composite to that to bring that tooth out, and then we'll go ahead and cure that into place. And there are definitely times where we do this in the mouth. We just slap it on there in the mouth, and it's important that we do this in the mouth from time to time, not just for the exercise, but to show us something about the nature of depth cuts. When we go in to place the depth cuts on this tooth now, if we've added, let's say, 1 millimeter of composite to the front of the tooth, and we go in and place a 0.5 millimeter depth cut now, that depth cut will be entirely in composite and will not touch the tooth at all. And that really tells us basically we don't need to do any reduction there. If the composite that we add in a specific area is say 0.3 millimeters thick, and we need to place a 0.5 millimeter depth cut, 0.2 of those millimeters will be in the enamel. So it helps us to be more conservative and not over prep teeth by placing the composite out there. We're not going to build this all the way out, of course, because we know that these two teeth, according to our ortho arch wire, were out too far to the facial. So what we're doing here is a combination of adding composite and some enamelplasty, so we have a nice ideal arch form. So let's begin with a little enamelplasty here on the adjacent teeth. In the mouth, when we're doing this, the patient is already anesthetized at this point, even though, again, it's just enamelplasty. As we go to some of these teeth, like this one that's really positioned out to the facial, we can end up being indented. So the patient is already anesthetized at this point. So we're going to go ahead and just use a lab handpiece and start to bring this tooth back a little bit by doing some enamelplasty. And that's exactly how we do it in the mouth with a coarse diamond. And then we'll go ahead and add some composite to this mesially rotated lateral as well, and that will be our indicator in the mouth that we don't need to do a depth cut very deep into the enamel because of the rotation we have here. Again, the distal half of the tooth, when we hit the arch wire in, appears to be in the correct position, so we're not going to add any composite here. It's just going to all be added to the mesial half of this tooth. I can see our cuspid right here is still out too far to the facial. Let's go ahead and do a little enamelplasty on the cuspid now. And just to help us visualize the arch form a little bit better, we'll go ahead and do a little enamelplasty on the lingual as well on these rotated teeth. It'll kind of throws it off when you're looking at the back. And this we would usually only do on a study model. In the patient's mouth, typically these rotations we leave in place on the lingual unless they end up being full coverage restorations. But typically on a veneer, we'll leave this here. The patient's tongue is used to having those rotations in place, and it's not a problem to leave it there. If it's full coverage, obviously we would change it. But on a study model, we'll go ahead and remove that just to make it a little easier to visualize what the proper arch form should look like. So now I've got our orthodontic arch wire sitting back over the teeth again. You can see the incisal edges now fall underneath that arch wire, which is what we're shooting for.
Зубную дугу практически уже исправили. Теперь, где места были препарированы зубы, их будут покрывать винирами.
Conservative on a couple teeth because now we're going to place some depth cuts in the areas where we built up with composite. We're going to do most of our depth cuts in the composite, not the enamel. But more importantly, in terms of the overall aesthetic results of the case, we've already removed, maybe 0.3 to 0.75 millimeters of enamel from the central incisors. And now we're going to go in and place our 0.5 millimeter depth cuts. So we're going to end up with a deeper reduction than most of us think of when we think about veneers. But by having a perfectly aligned arch now and now doing our depth cuts, we allow the laboratory technician to give us back a case that's going to be in perfect alignment. When you take a misaligned case and simply place depth cuts right into it and don't take the rotations and all those things into account, what you end up with is getting a case back that still has alignment problems. The technicians are just that. They're not magicians. They can't do instant orthodontics unless we give them the room to do it. So by going in ahead of time and doing some enamelplasty and adding some composite, what we do is called an IntelliPrep. We intelligently prepare the teeth by making sure that we don't over-reduce in areas like the lateral incisors where we don't need to, but we do more of an aggressive reduction on the central incisors, for example, where we need it to achieve the type of result we want to achieve. So let's go ahead and place some depth cuts into our teeth now. If you've had the opportunity to watch any other of our DVDs, such as the Wolfram or the PFM technique DVD, you'll know my first step in my reverse preparation technique is a gingival depth cut, and I use a round diamond just like this one. I use this in the veneer technique as well, although with the thinner restoration margins that we have on veneers, you don't necessarily have to do this. Sometimes I do, sometimes I don't, but I'd like to show it to you now. Again, it's the first depth cut we place it right at the gingival margin, so we do not touch the tissue at all. And we place it so that the burr sinks in halfway, and it gives us a perfect half circle at the level of the gingiva. This is going to end up giving us a fantastic margin when we're done prepping the tooth, because right now it's a perfect half circle, and when we're done prepping the tooth, it's going to give us a perfect quarter circle, which is, after all, what the ideal chamfer looks like. These are the typical burrs most dentists are familiar with when it comes to placing facial depth cuts for porcelain veneers. The one on the left is
Специальные боры
cut. This would be used for
для того,
breast
чтобы
augmentation.
сохранить размеры снятия твердых тканей.
This one on the right is a 0.3 millimeter depth cut, and this would be used with
feldspathic porcelains like some of the Nortaki
3
porcelains
миллиметра, 5 миллиметров.
or things like that. So it's a pretty minor difference, 0.2 millimeters. But again, we want to remove the least amount of tooth structure possible to end up with the desired outcome, which is a natural, nice-looking smile for the patient. Since we've already done some reduction to get the teeth back into alignment, we'll go ahead and use the 0.3 millimeter depth cuts on the facial surface. And we will now blend all our facial depth cuts, and we'll blend that with the gingival depth cut we made with the round burr as well. Interproximally, since we don't have any diastamal we want to move, we will prep halfway into the contact. Typically, we don't break contacts unless we have a midline that is shifted to one side or the other that we need to move. Again, on this lateral incisor, I'm in all composite here. At the very end, I will
По
take
этим
off
ориентирам
composite bits.
уже алмазным бором снимаются
Reduction, the next step is the incisal
и
reduction.
придается форма.
We really want to get a nice, natural-looking incisal edge.
0,3-0,5 служит для того, чтобы не углублять, не снимать лишнюю ткань.
A burr, a diamond burr, where I know the thickness of the burr happens to be 1.25 millimeters. We'll place some depth cuts in the incisal edge and then connect those. We're also going to do 1.5 millimeter depth cuts on the bicuspids as well, because we're going to shoe the entire buccal cusp. So we're going to reduce the buccal cusp 1.5 millimeters, and we're going to take the preparation all the way to the central groove. So in this reduction, we're actually going to take the tip of the burr and place it in the central groove, and then drop it in 1.5 millimeters. If there's a one-surface amalgam present in the bicuspid, that amalgam usually will be about 1.5 millimeters deep. And we'll just take out that amalgam and make it part of the preparation. So it'll almost be like an inlay connected to the veneer. As we reduce the incisal edge, we did it perpendicular to the long axis of the tooth as we took off our 1.25 to 1.5 millimeters. And really, we're going to blend this right into our lingual margin. We're not going to place any kind of a chamfer or anything fancy on the lingual. We're just going to take the burr from being perpendicular to the incisal edge and really tilt it back at about a 30-degree angle and prep back onto the lingual surface. So the incisal edge is going to look like a long, kind of a butt joint, and it's going to be slanting about 30-40 degrees towards the lingual, this butt joint.
Обработка
And
идет
this is going to give us some mechanical
эмали
retention
также и с темной стороны.
because it is slanting towards the lingual. So when this restoration is made, there is in fact some retention, keeping the veneers from popping off when the patient goes into protrusive.
Практически получается трехчетвертные коронки.
To prepare a shoulder or a chamfer on the lingual, you just end up with too thin of a wall of ceramic material on the lingual. So we start with the burr perpendicular to the long axis, like we've been doing our reduction, and then we just turn it back 30 to 40 degrees and make our butt joint slant towards the lingual. A very easy and a very functional and effective lingual margin. Now that we've finished the preparation, let me take one of these teeth out so we can look a little closer at a few of the nuances here of the veneer preparation. I've used a extra fine point Sharpie to color in the prep because I want to point out a couple of the nuances of the prep. And you'll notice when I turn it to the side, we're looking at it from the distal here, and you can see where we've prepped what's called either a dog leg or an elbow, where the prep actually goes towards the lingual, this way towards the lingual, so that it doesn't break contact. So this tooth, this is the contact area of the tooth right here. This tooth, when it's in the arch, still has an interproximal contact with the tooth next to it. And what we're doing is tilting the burr lingually underneath the contact, but it's above the papilla. It's coronal to the papilla, which is right here. So this dog leg or this elbow wraps from the facial surface mesially and distally on all these anterior teeth and goes below the contact area and above the papilla, so that when the patient, turns their head to the side, or somebody's standing to the side of the patient and watches them smile, that it covers up this part of the original tooth shade. If you take a tooth that's an A3.5 and make it an A1 or a B1, and you don't do this elbow or this dog leg preparation, you'll be able to see the patient's original tooth color right here in this little square tooth structure. I've made that mistake before and obviously learned that I needed to prep this. Now, if you break all the way through here and break contact between the two teeth, you will solve that problem as well. But if you're being conservative and leaving contact between all of these teeth, you still need to prep this small bit of tooth structure right here by tipping the burr towards the lingual underneath the contact but above where the soft tissue papilla is going to be. If you're a left-handed dentist like I am, you will tend to miss this on the distal surface of teeth like 6, 7, 8, and 9. And if you're a right-handed dentist, you will tend to miss this on the distal surface of teeth like 9, 10, 11, and 12. So it's something to watch out for, and you really need to have the patient turn their head to the side to be able to do that. As you look at the front, you'll notice that the outline of the facial aspect of the prep should be in 3 planes. And you should have a gingival plane, a middle plane, and an incisal plane. One of the things you want to make sure you do at the end of the prep is to take, in the incisal third, you can take a soft flex disc from 3M or a burr. I like sandpaper disc. And really make sure you prep this back in the incisal third so that the tooth is not flared out to the facial, which will give you either a buck tooth or a very opaque looking incisal edge. So you want to make sure that incisal third has been taken back towards the lingual, preferably with a sandpaper disc. As you look over to the side, you'll notice this kind of prototypical look of a veneer prep where we have the incisal reduction here, and then it goes down on both sides. And this area where it goes down on both sides is where we connect our incisal reduction with our lingual reduction. So as we turn this tooth over to look at the lingual reduction, I'll flip it over here. You can see the lingual reduction does not go down to the cingulum. We have preserved natural tooth structure here because we want the lower anterior tooth to still contact natural tooth structure. We want enamel on enamel here, not enamel on porcelain. If I turn this to the side, hopefully you'll be able to see the 40-degree slant that we talked about earlier. So when we do the incisal edge reduction, initially it is done perpendicular to the long axis of the tooth, and then when we blend that into our lingual margin, we turn the burr 30 to 40 degrees to the lingual and prepare towards the lingual, so that when the lab technician builds the veneer for us, we're going to have some mechanical retention when the patient goes into protrusive and the lower anterior tooth slides along the cingulum and rides upon the incisal edge. Something that's going to keep that veneer from being displaced towards the facial. So again, the notch that you see here and the notch that you see here are in fact the blending of the incisal edge reduction and the lingual margin. Remember to keep the incisal edge parallel to the patient's inner pupillary line. So even if you don't do a stick bite where you use bite registration and a little paintbrush to show the technician the smile line, make sure you keep these incisal edges of the preparation parallel to that line that connects the patient's two pupils, because when the impression is sent to the lab and poured up, they're going to mount those incisal edges parallel to the tabletop, and that's what's going to give them their smile line. So if you do that correctly and keep these edges parallel to the patient's inner pupillary line, you will not get a case that comes back with a canted smile line. And again, you can see the nice gingival reduction that's been done here with the use of the round burr and the reverse preparation technique. And again, when we cut into the side of that, it gives us a perfect half circle. And by the time we do our axial, our facial reduction here, we end up with a perfect quarter circle, which is the best margin. It's either a deep chamfer or a shallow shoulder, whatever you want to call it. But the good news is we have enough reduction in the gingival third, and the margin is uniform all the way around, so it's very easy for the technician to wax it.
Ну вот вы посмотрели еще одну методику, как идет исправление зубного ряда.
This next case is an interesting one. This patient had veneers done, actually pretty good looking veneers from a local dentist, and you can see him right here on 6 through 11. So that's kind of mistake number one, is just to do veneers on teeth 6 through 11. But notice the huge value difference after the patient bleached their teeth. You can see the bicuspids and the first molar on both sides on the upper arch are very white and look very nice. and the patient was disturbed that the veneers on 6 through 11 would not change color and not get any lighter. And of course, this is one of the compelling reasons when doing an aesthetic case like this to tell patients about whitening, about vital bleaching, and say, would you, like to consider bleaching your teeth before we get started on this treatment? I can almost guarantee you when the dentist originally did these 6 veneers that they did in fact match the surrounding dentition, and at that point looked very nice. And then when the patient did decide to bleach their teeth a couple of years later, now all of a sudden they don't match. And so even though I liked the contour, the shape, the surface texture, I liked almost everything about these veneers. They really were great veneers. They were really dark. So I'm using the Vita Easy shade here to go back to the patient's bicuspids and molars and take a look at what the shade is going to be here. And it was in fact one of the bleached shades as we would expect. The teeth were not dehydrated. She hadn't actually bleached her teeth in about 5 weeks, and so I knew I was getting a stable shade for these teeth, and we were going to have to go pretty light to be able to match the new veneers with the bicuspids and molars that she currently had. Since these are all existing veneers, we're not going to do any depth cuts here. We're just going to go ahead and begin to remove the old porcelain veneers. Again, this is an old diamond that I don't mind dulling up on some old porcelain veneers, and we'll get a look and maybe be able to estimate and see exactly how much reduction was done here. I really don't know what to expect here. I do know, because she told me she wore temps, that these were not no prep veneers. I also know that because they look pretty darn decent, and no prep veneers are very, very limited in their indication. So as I begin to prepare these, I get a feeling for how much reduction was done, and what if in fact we have to do any more, although I don't think we're going to have to. So we'll just wait and see as we remove the veneers here, and I'm also going to be very interested to see what the color, the shade of the substrate of the, or the subshade as some would call it, is, and see whether or not the teeth, will match the other teeth. When you look at those bicuspids and molars and see how white they are, you expect these teeth would be somewhat light as well, or at least have the potential to get that white. So we took it off, and it appears to be just about 1 millimeter of reduction that was originally done. Again, we're going to use our 2-cord technique, so I am placing the 00 cord right now from Ultradent, a hollow knitted cord, and using the cord packer to tuck it in. As I get in approximately here, I can stop, and I'll actually go ahead and cut the cord right in this area with the scissors, and then just tuck that little end in towards the lingual. Since there's going to be no preparation on the lingual down in the area of the gingiva, there's really no need to pack a cord all the way around. So I'll clip that with the scissors right there by the papilla, and then just kind of tuck that end towards the lingual. Once the 00 cord is in around all the preparations, now we can go ahead and take our, you can see the red stripe on it. This is a 30 micron diamond, a very fine diamond. The 00 cord has moved the gingival tissue back about 1/2 to 3/4 of a millimeter, and this allows us now to drop our margins down to this level. What this means is when we remove the 00 cord, our resultant margins will be just about 1/2 millimeter subgingival, and I'm very comfortable with our porcelain veneer margin being about 1/2 millimeter under the free gingival margin. When I'm not comfortable with this, taking a burr that's rotating 200,000 RPMs, 1/2 millimeter subgingival. So by waiting to prep the gingival margin until the first cord is placed, we get a slightly subgingival margin without ever having to run the risk of taking a diamond burr subgingival, which is great. This is an Arkansas stone, used to be used in the old days to contour composite. We're using it here to smooth off tooth structure. Again, we used to hear a lot about micromechanical retention, but when you look at models that have been poured up by other dentists and you find yourself saying those are great looking preps, they're always nice and smooth. With the adhesive dentistry techniques we have today, we're able to smooth off the preparation, so there's no big chunks out of the margin with the laboratory technician will have to guess, where is this supposed to be? These are Softlex discs from 3MSB. These black ones are the coarse ones, and I'll also use the blue disc, which isn't quite as coarse. And we're using these to round off and transition between the incisal edge. So especially at the corners, we're going to round off the corners with the sandpaper disc so that when it's poured in the laboratory, those little pieces of stone don't break off. This is a 2E cord from Ultradent. Slightly larger cord, obviously, than the 00 cord, but it is still hollow, and so it compresses well as we put it into place. Same thing here, we're just packing on the facial from papilla to papilla. No need to pack the lingual. So we start with the free end, in this case on the distal gingival embrasure, and as we work our way around the front, I will pack till I get to the mesial embrasure, we'll cut it with the scissors, and then I will tuck that loose end under the contact towards the lingual. There are times, especially on lower anterior veneers, where you won't be able to fit this cord into place, this number 2 cord. I can fit it into place on the maxillary about 90-95% of the time. If it won't fit, I will use a number 1 cord instead of this number 2 cord, but it provides me with such a great amount of retraction when I go to take the impression, and I get such great results. And when the lab calls and says, boy, this impression really turned out fantastic, they didn't used to do that when I was using the 1 cord technique, and now they do. So I know they really are seeing a difference in my impressions with the 2 cord technique. You'll notice as I pull these number 2 cords out from around the teeth that there will be no bleeding here. There's never any bleeding in this 2 cord technique. Very, very predictable, and you just don't get any bleeding. Now, if I pulled that bottom cord out right now, I would get bleeding. Or if this was a 1 cord technique and I pulled that cord out, I would get bleeding. But not with the 2 cord technique where the bottom cord stays in place. This is the medium body viscosity capture that I'm using as my syringe material. Why medium viscosity? Because it's got a higher tear strength. And with that number 2 cord that I packed into place, I'm going to get a ton of subgingival information here for the laboratory. They're going to be able to see at least a millimeter of tooth structure apical to the margin. And since my impression material is going so far subgingival, I want to make sure that I use something with a high tear strength so that I don't have tags of material tearing off in the pocket around. And you can see all 6 of the first cords have stuck to the impression material. Usually we would do 8. This is the probably only case you'll ever see me do where we do 6 veneers, because we were replacing 6 existing veneers. And you can see now there's starting to be some bleeding, and the reason why is because those first cords came out with the impression. No big deal if there's bleeding here. The only time we don't want bleeding is during the active impression phase. Bite registration is squirted on teeth 6 through 11, only on the prepared teeth, nothing on the unprepared teeth or the soft tissue.
Я не хочу повторяться, но все делается силиконовой массой. Опять делается регистратор. Здесь методика установки виниров для исправления цветовой гаммы.
And it's canted to one side to shorten that side enough to make it look good. So using this stick bite, where the stick itself is parallel to the patient's inner pupillary line, is very, very helpful. Here's an alternate temporary technique for veneers that I don't use anymore. I use the putty wash combination that you've seen in this DVD exclusively now, or almost exclusively now. But here's a way we used to do it, where you can build in some incisal edge translucency. You'll notice we have a suck down stent over the patient's pre-op model, or you could do it over a diagnostic wax-up model if you wanted to as well. And then what we've done is take some 0.4 flowable composite from Kerr that's clear, and you can tell we put that down inside the stent where the incisal edge would be, and then we've added some mamelons as well. And then we've cured it from the outside with a curing light so that this flowable composite goes along all of our temporaries, and then it comes up vertically to represent the mamelons as well. And now we backfill this with some bisacryl of whatever appropriate shade you'll be using, B1 or A1 or bleach shade, whatever it might be. So what we're hoping to do is give it kind of the look that we get with biotemps. Biotemps have a great, great incisal edge on it because they're hollowed out denture teeth, and we're trying to kind of recreate that a little bit with our temporaries, and we do it by using that clear flowable composite inside the stent. So we cure that with the light, then we put the bisacryl inside that stent, and then we place this over the patient's prepared teeth, and then we begin to check it to see. It takes about 60 to 75 seconds for that bisacryl to set, and once that has set, we can go ahead and peel our suck down stent off the teeth. One of the things I've noticed is, even though you would assume that a suck down vacuum form stent like that would be extremely accurate, it's not nearly as accurate as the putty wash technique you've seen elsewhere in this DVD, so keep that in mind. you'll notice that because this is 6 teeth and not 8, 10, or 10 teeth, we've been able to remove these temporaries from the mouth. We can always do this when we're prepping 4 veneers. We can take this off and cement them back into place. But once you're doing 8 or 10 veneers, it is typically the bicuspid temporaries that break off from the rest of them, and that's why we typically lock them into place. So in this case, since we're only doing 6, since the patient already had porcelain restorations on her bicuspids, or we were just replacing the 6 veneers from 6 through 11, we were able to wiggle these off and then shape and do our trimming around the gingival margin out of the mouth, and then we're going to put these into place with temp bond cleared because we don't want our temporary cement showing through these temporaries. So the temp bond clear is a fantastic way to be able to do that. So you can see how nice the temporaries look while they're in place using this technique. We've removed the temporaries with a pair of curved hemostats, and first thing we're always going to look at is going to be the tissue to see if the tissue has done well. If the tissue has not done well over this 2-week period, it's going to be very difficult to bond something into place. So hopefully we're going to look and see nice tissue because we really spent some time adjusting the embrasures when we place these. If you have bisacryl material stuck between the teeth, as so usually happens, again, we're using the serrated saw, handheld saw from Wrestler to go back and forth and just pop loose any bisacryl that's gingival to the contact area. You want to be real careful you don't fly by that and take this saw right into the papilla. That'll certainly start some bleeding that you won't be able to catch up with. This is from Whip Mix. This is some pre-mixed pumice called Preppies, and we're using this to clean off the teeth, and we use this in conjunction with Conceptus to disinfect the preparations. And as we go through, the nice thing about this pumice is that it's nice and creamy and pre-mixed, and unlike the pumice that we have, in the lathe in the back of the office for removable, this is clean and this is sterile and works very well for the purpose we're using it here for. You don't have to mix it with water right out of the little package. It works fine. We're going to take the veneers now and use the Try and Cement. This is Ivoclar Viva Dense Appeal Cement, and this will be, again, the translucent shade. And we're going to try these in, being careful to clean up the Try and Cement from the gingival embrasures and the incisal embrasures so the patient can really take a look at these veneers when they're in place and make a decision if she likes how they look or not based on this try-in. We'll also snap a few digital photographs, then I'll take that card out and put it in my laptop and take a look at those pictures. For me, there's no better way to evaluate a case than looking at a still photograph on a laptop. When I'm looking at the patient who's moving back and forth and their lips are moving, I can get an idea whether or not the case looks natural, but when it comes to really critiquing the case, I find it to be much easier to do with digital photography right on the computer. Obviously, if you're still shooting, you wouldn't be able to do that. So we're trying in the last of the veneers right here, and we look to see if we like it. So at this point, we'll give the patient a mirror, typically without me in the room, so they won't feel influenced to answer one way or the other, while my assistant asks them what they think about their teeth, and they'll take a look in a large patient mirror and then give my assistant any feedback they might have. Total etches down to about 10% of the veneers I place now. That's how high my confidence level has risen for the self-etch bonding system. So I'd say about 1 out of every 10 times I will use the total etch system, usually based on just a gut feeling of looking at the teeth and deciding whether or not we have enough tooth structure to bond to and what the type of tooth structure is. So if we've done a minimal veneer and all my exposed tooth structure on the veneer plate is still enamel, then I don't worry about bond strength at all. If it's all dentin, I know that that bond has a little witchcraft going with it, and we probably use something a little bit stronger like total etch. Most of the time it's going to be a self-etching primary. This is Optimon Solo from Curve being placed on the central incisors. Once we have etched,
Сейчас идет фиксация
separate the solvent in just a minute.
и закончим.
You can either cure or not cure this, just based on how you feel about film thicknesses. In school, dental school, we were taught not to cure this. I've cured any of the ones that measure thin at CRA. We cure ahead of time and then place the veneer cement into the veneer and seed it over that and then cure it together. But if you don't want to cure it, hopefully you have a good, nice and strong curing mic that will go through the veneer, through the cement itself and all the way down to the bonding agent that's on the tube. Both the central incisors are put into place now with the veneer cement. You can use your fingers or you can use orange wood sticks to make sure they are seated all the way. And then we've got a 2 millimeter tip here in the middle of the veneer, and we're just going to with an Explorer. This is your goal. This is what you want to see right here, which is a veneer cement behaving exactly like a crown and bridge cement. That's certainly one of the characteristics of an ideal veneer cement. So remember, the output of the light, the absolute output, is way lower for the 2 millimeter tip than your standard tip sizes. So even though it appears that we had that light on for a long time, it was the correct call because of the low output of the light. As you saw, we were still able to, with just the Explorer, clean things up.
Вот здесь
And we're still
показана
able to work in approximately
очередная фиксация виниров,
clean up some
как
excess
все это
cement,
происходит.
slide floss with a knot in the middle. Once we have
Шлифовка,
the excess off
полировка.
A9, we'll go through our 40-second complete cure by curing both on the facial and the lingual to make sure those are in place. When you're doing it like this with the central incisors first and the rest of the teeth afterwards, make sure you don't leave any excess veneer cement on the adjacent and lateral incisors afterwards. That would certainly keep the next restorations from seating into place. So again, one of the things I like about loops is being able to look critically at the lateral incisor next to the central veneer that I just put on, and making sure that there is no veneer cement that's stuck there that would, break the lateral veneer while you try it into place or something like that. So here's the total etch technique that you saw. Again, this is going to be 10 seconds on dentin, 15 seconds on enamel, and then we will rinse that off and then place our OptiBond solo bonding agent again, and then follow the rest of the bonding steps for these veneers as well. Again, by doing a minimal cure, we're able to clean off the excess cement with just an Explorer at this point. As I mentioned, other times we will use a scalpel if it's a little more tenacious and we don't want to bend the Explorer. But we'd like to be able to do it without having to use rotary instrumentation such as burrs. So we'll continue to clean up as much as we can with dental floss, with a knot in the dental floss. Once we've removed the excess cement on the facial and lingual surfaces and interproximal surfaces, we will go ahead and go to our 40-second cure on each of the surfaces involved. And now we're moving over to the right-hand side to place the last two veneers over there. Once we have finished putting all the veneers in, we're going to use the finishing kit from Brasso that has the dialite wheels on it and a couple
Уважаемые студенты, вы посмотрели 5 методик препарирования зубов, фиксация виниров. Если что-то будет у вас непонятным, мы это разберем на практических занятиях. Благодарю вас за внимание.